This time we are moving on to the autonomic nervous system. As the name is suggesting, it is running automatically under the central control of hypothalamus, but it will require some sympathetic and parasympathetic components which should be further carrying out the activities. Now, as you see, one question is in front of us asking about the sweat gland. Understand that normally most of the glands in our body are parasympathetic cholinergic, but sweat is an exception and it is under the sympathetic system. So mostly glands are parasympathetic cholinergic, but sweat is an exception. So what could be the answer then? D cannot be the answer. See, choice number C appears to be the best possible answer because most of the sweat glands are actually sympathetic and adrenergic. But then we also have got sympathetic, means most of the sweat glands are sympathetic cholinergic, but we have got few sympathetic adrenergic sweat glands also. That means the question has double answer. Yes, it is. So which one should I take as my first answer? Actually, in this question, you have to tell that C is a better answer than B because mostly the sweat glands are sympathetic and cholinergic, and there are few sweat glands which could be sympathetic and adrenergic as well. So maybe the question has double answer, but still the most appropriate will be the choice number C. Now, once you say C is better than B, let's move on to the description of sympathetic parasympathetic system. You will find that the sympathetic system is called as thoracolumbar flow because the sympathetic neurons are seen in the thoracic and upper lumbar spinal cord. Thoracolumbar flow, sympathetic neurons. What about the parasympathetic? As the name is suggesting, para means on the side. Para means on the side of the sympathetic. So if you have sympathetic here, on the side of that is parasympathetic, which is actually craniosacral flow. Why would you say craniosacral flow? Because there are some cranial nerves and the sacral nerve. Actually, cranial nerves will be coming from the brainstem and the sacral nerves will be coming from the sacral spinal cord, number S234. So spinal segment sacral S234 will give you the nervi erigantes, whereas there are some cranial nerves. So cranial nerves, sacral nerve, craniosacral flow is parasympathetic flow. Now, the organization of autonomic nervous system is that it is ganglionated. There are ganglia in the system. Could be sympathetic ganglia or could be parasympathetic ganglia. There is one CNS neuron which is the nucleus basically, and then there will be the PNS neuron, which is of course the ganglia, and effectors are three. So what are the three effectors in autonomic nervous system? The smooth muscle, cardiac muscle, and the smooth muscles of the gland, which is also called secretomotor fiber. So if you're talking about the effectors of the autonomic nervous system, there is smooth muscles, cardiac muscle, and the glands. Glands also have smooth muscles, so secretomotor fibers. Now, as we are talking about autonomic nervous system organization, you will see there's a preganglionic fiber having some features and there are postganglionic fibers having some features. We have to discuss about that because there are questions upon that. See, parasympathetic ganglia are close to the target organ. And because the parasympathetic ganglia close to the target organ, it is understood that the postganglionic fibers will be short length fiber as compared with the preganglionic fiber. So since the parasympathetic ganglia are close to the target organ, it is the postganglionic fiber which is short length. What about the sympathetic ganglia? Actually, sympathetic ganglia are close to the CNS. And since the sympathetic ganglia are close to the central nervous system, it is obvious that the preganglionic fiber will be short length. So for the sympathetic system, it is the preganglionic fiber which is short length, and postganglionic will become long length fiber. Also understand that maybe it is sympathetic or parasympathetic system, only the preganglionic fibers are myelinated fiber. Only the preganglionic fibers are myelinated fibers. Then what about the postganglionic? Maybe sympathetic or parasympathetic, the postganglionic fibers are non-myelinated. They'll be gray fibers. They are gray in color, gray fibers. Now, they're not white. No, they are not white. Okay. There is one more thing. As you're talking about the sympathetic or parasympathetic neurons, you have remembered they are in the lateral horn cells of the spinal cord. So in the lateral horn cells of spinal cord, you may have sympathetic neuron or maybe the parasympathetic neuron, and they have to synapse with the ganglia, and the ganglia are using acetylcholine as the neurotransmitter. Maybe it is sympathetic ganglia, parasympathetic ganglia, they use acetylcholine at the ganglion level. What about the effector level? Effector, which could be, cardiac muscle, smooth muscle, or gland, it is different. Actually, if you say acetylcholine, then it is parasympathetic system mostly. And if you say adrenergic pathway, then it is sympathetic. So usually it is seen that sympathetic system is adrenergic pathway at the effector level, whereas the parasympathetic system is cholinergic at the effector level. Now we will draw a diagram for the same, but remember, as we said, preganglionic fibers are myelinated fibers, maybe sympathetic or parasympathetic, and the postganglionic fibers are unmyelinated. So postganglionic fibers are unmyelinated fibers. Maybe it is sympathetic or parasympathetic system. This is one diagram which we are supposed to draw, and let us do that. It'll be kind of a revision now. So what you're talking about is the autonomic nervous system, which is actually two components. It could be the sympathetic system or it could be the parasympathetic system. If you say it is sympathetic system, then it is the thoracolumbar flow. Why it is called thoracolumbar flow? Because we have got sympathetic neurons in the thoracic and upper lumbar spinal cord. And if you say parasympathetic, then it is craniosacral flow. Why would you say it is craniosacral flow? Because there are cranial nerves and the sacral nerves constituting the parasympathetic system. Now this system is ganglionated system. So let us talk about the ganglia here. You have to discuss, there is one neuron in the CNS, one in the PNS, and there will be three effectors. And what are the three effectors we know in the autonomic nervous system? They are, could be the cardiac muscle, or that could be the smooth muscle, or that could be the glands. Glands also have smooth muscles. This is called secretomotor fibers. So it could be controlling the cardiac muscles, or it could be controlling the smooth muscles, or it could be the smooth muscles of the gland, which are called secretomotor fibers. Now, once you have told that, let us look at the boundary line, CNS, PNS, and effector. In fact, you are going to talk about the CNS nuclei, because if you have neuron bodies in the CNS, they are nuclei. If you have neurons in the PNS, they are ganglia. So ganglia are actually collection of neuron bodies in the peripheral nervous system, and the nuclei are collection of the neuron bodies in the central nervous system. Now let us start with the parasympathetic system. As you are talking about the two of them, we are starting with the parasympathetic system. Parasympathetic system is having one neuron body in the CNS, and the preganglionic fiber is quite long because the ganglia, parasympathetic ganglia, are close to the effectors. As you say, the parasympathetic ganglia close to the effector target organ. The postganglionic fiber is short length fiber in a parasympathetic system. And which transmitter it is using? Ganglion level, it is always seen that acetylcholine is working. And what about the effector level? If it is parasympathetic, again acetylcholine. Acetylcholine cholinergic system is mostly parasympathetic on the effector level. Now let us look at the sympathetic as well. As you are talking about the sympathetic, you will find this is the sympathetic system. You have one neuron body in the CNS, the nucleus. And since the ganglia are close to the target organ, you see, the sympathetic ganglia are close to the CNS, central nervous system. Since the sympathetic ganglia are close to the central nervous system, it is understood that the preganglionic fibers are short length fiber, and there is a postganglionic fiber which will become long length fiber. If you're talking about sympathetic system, since the sympathetic ganglia are close to the central nervous system, it is understood preganglionic fiber is short length and postganglionic fiber is long length. And effectors are the same: cardiac muscle, smooth muscle, or secretomotor fibers. Now understand, when you are talking about the sympathetic or maybe parasympathetic, they use acetylcholine at the ganglion level. So ganglion level, there is acetylcholine, maybe it is for sympathetic system or maybe it is for the parasympathetic system, but at the effector level, there's a difference. You will see the sympathetic system is mostly adrenergic, not necessarily all the time. The sympathetic system is adrenergic usually, but sometimes there are exceptions. Like on the skin, it is using acetylcholine. So there will be cholinergic pathway for skin. Like what in the skin? We have said the sweat glands. The sweat glands are usually sympathetic adrenergic. So we are talking about the sympathetic system, and at the ganglion level it is using acetylcholine, but at the effector level it is usually adrenergic pathway. But skin is an exception because on the skin it is cholinergic, sympathetic cholinergic. For example, sweat glands are mostly sympathetic cholinergic glands. So this was our discussion. We also have told that preganglionic fiber, maybe it is sympathetic or parasympathetic, they are white in color. Why they're white in color? Because they are myelinated fibers. So since the preganglionic fiber, maybe it is parasympathetic or sympathetic, both are myelinated, they'll be white in color. But if you're talking about the postganglionic fiber, then they are non-myelinated fiber. So maybe it is the parasympathetic or maybe it is the sympathetic system. But if you're talking about the postganglionic fibers, they are non-myelinated fibers. Now, once you know that, we can move further. We want to talk more about the parasympathetic system and then we can move on to the next, which is sympathetic. So as you start with the parasympathetic, there's a question asking about the vagus nerve. Vagus nerve is a parasympathetic nerve. Have you been to dissection hall where we were dissecting the vagus nerve area? Which color vagus nerve is? White. And because vagus nerve is white in color, what do you think is the answer? Yes, this. Why? Because it is white in color. It is carrying the preganglionic fiber. It cannot carry the postganglionic fiber. Understand, vagus nerve is coming from central nervous system and it is a parasympathetic nerve which will be myelinated. So it is white in color. So it cannot carry the postganglionic fiber. It was carrying the preganglionic fiber. Remember, maybe in the number 3, 7, 9 or 10, all the parasympathetic nerve, even the nervi erigantes are white in color. The number 3, 7, 9, 10 or the nervi erigantes, the parasympathetic nerves, they are white in color. So they can carry only preganglionic fiber. That's why choice number B is wrong. Yeah, they are asking for exception. The exception is choice number B. You mean to say vagus supply heart and lung? Of course, vagus is supplying heart and lung. See, your answer is choice number B. And of course, vagus is supplying heart and lung. Actually, it will cause bradycardia and bronchoconstriction. Vagus nerve will cause bradycardia and bronchoconstriction. And vagus nerve is supplying till the midgut. So it will supply till the right 2/3 of the transverse colon. Vagus nerve supply till the midgut, so it will supply till the right 2/3 of transverse colon. And it is vagus nerve which is parasympathetic system. Parasympathetic system is for bladder wobble evacuation. If you say it is for bladder and wobble evacuation, how? Parasympathetic system do that by increasing peristalsis and relaxing sphincter. So parasympathetic system like vagus nerve is for evacuation. Like what is it doing to the stomach? In the stomach, if you tell, then it will be increasing the peristalsis. And if it increases the peristalsis of the stomach, the vagus nerve, if you're talking about the vagus nerve, which is going to increase the peristalsis of the stomach, what will it do to the pyloric sphincter? It will relax the pyloric sphincter. And what will happen when you relax the pyloric sphincter? Then whatever the content are there in the stomach, they will be evacuated into the duodenum. So content of the stomach will be evacuated into duodenum. Yes, evacuation. The stomach is evacuating into the duodenum by the vagus nerve. And what will happen if I cut the vagus nerve? Vagotomy. I'm cutting the vagus nerve, vagotomy. I have a case of peptic ulcer. So you got a case of peptic ulcer and you're doing vagotomy for that? Yes. Tell me what is the side effect? Side effect is you cannot evacuate the stomach into the duodenum now. There'll be retention syndrome. The side effect of vagotomy is retention syndrome. What is retention syndrome? It is that the stomach is not able to push the food into the duodenum. So what should I do? You have to anastomose stomach with the next possible small intestine component or whatever. You have to do some shunt operations, or you could go for some highly selective vagotomy and all that. But the thing is, if you compromise the vagus nerve, then you're compromising the evacuation, resulting in retention syndrome. This is essential to note. So we'll keep our answer as choice number B. Yes, that is the answer. And let's proceed further. As you are talking about the parasympathetic system, it is the cranial nerve, cranial sacral flow. If you say it is cranial sacral flow and sacral nerve, which sacral nerve, which cranial nerve? Cranial nerves are number 3, 7, 9 and 10. 3, 7, 9, 10 carry parasympathetic fiber. And what about the sacral nerve? They are actually called nervi erigantes, also called pelvic splanchnic nerve. S234. If you say they are S234 nervi erigantes or they are the pelvic splanchnic nerve, why would you say pelvic splanchnic nerve? Because they are controlling the pelvic viscera. And what pelvic viscera you are talking about? You know pelvic viscera? First, there is urinary bladder, behind that is uterus, and behind that is the rectum. So, that is the pelvic viscera. So, first there is urinary bladder, and behind that is uterus, and behind that is the rectum, and that is the pelvic viscera controlled by the nervi erigantes. Yes. What they will do there? What they will do is parasympathetic evacuation, bladder wobble evacuation. There will be defecation and there will be urination. So, as you activate the nervi erigantes or what is called as the pelvic splanchnic nerve, there will be defecation and urination, and they also cause erection. So, parasympathetic nervi erigantes cause erection. Yes, that you remember. Okay. Now, let us look at the third nerve. Third nerve is coming from the brain stem and is having a ganglion in the orbit called ciliary ganglion. We have to draw a diagram for that. So, oculomotor nerve number 3 is coming from brain stem having a ciliary ganglion in the orbit to control some smooth muscles in the eyeball, which we have to name in a diagram. And what about the seventh nerve, facial nerve? Facial nerve comes from the brain stem and having two ganglia, namely pterygopalatine ganglion and there is a submandible ganglion. This pterygopalatine ganglion and the submandible ganglion control the 5 glands on the face. Which 5 glands on the face controlled by facial nerve? Then we have to draw a diagram for that. Now, the ninth nerve is coming from the brainstem and is synapsing in the otic ganglion to control parotid salivary gland. If you want to control the parotid salivary gland, use the otic ganglion, which is itself controlled by the glossopharyngeal nerve, number 9. What about the nerve number 10? It's the longest cranial nerve. Why? Because vagus nerve is supplying the head neck region, thorax region and the abdomen region and becomes the longest cranial nerve. And this nerve has the widest distribution in the body. Widest distribution means it is supplying not only the head neck region but thorax and the abdomen region also. So widest distribution, vagus, and longest cranial nerve, vagus. What is vagus nerve doing in the head neck region? It is secretomotor. Parasympathetic system is secretomotor. Parasympathetic system increases the glandular secretion. So, vagus nerve is secretomotor in the head neck region. Yes. And what is it doing in the thorax? I told you, bradycardia and bronchoconstriction. Bradycardia and bronchoconstriction. And what is it doing in the abdomen region? Bladder wobble evacuation. Bladder wobble evacuation. Remember, vagus nerve is supplying till the midgut, means till the right 2/3 of the transverse colon. If you say vagus nerve is supplying till the midgut, till the right 2/3 of the transverse colon, will it supply the vermiform appendix? Yes, of course, it will supply the vermiform appendix because vermiform appendix is a part of the midgut already supplied by vagus nerve. So, who is going to supply the hindgut then, which includes the splenic flexure and the rectum? If you're talking about the hindgut, which include the splenic flexure and the rectum, then it will be the next set of nerve. And who is that? That must be the nervi irrigantes. Now, nervi irrigantes are going to take care of the hindgut, which is splenic flexure and rectum part of the hindgut, but they also take care of the pelvic viscera. We have told nervi irrigantes, also called pelvic splanchnic nerve, cause bladder wobble evacuation by increasing peristalsis, relaxing the sphincters. They also cause erection in the genital system. Now, once you have that orientation, tell me, now number 3, 7, 9, 10, nervi irrigantes are which color? What is the color of these nerves? White. Why? Because they are carrying the preganglionic fiber, they are coming from the CNS. So they are myelinated fibers. All are white in color. Then who is carrying the postganglionic fiber? Postganglionic fibers usually have no names. If you say postganglionic fiber usually have no names, then how do they reach their respective target organ? I'll tell you that in the head and neck region, the postganglionic fibers are carried by the branches of trigeminal nerve. So you mean to say in the head neck region, the postganglionic fibers are carried along the branches of trigeminal nerve? Yes, it is the trigeminal nerve which will carry the postganglionic fiber. Understand? This is trigeminal nerve. It is going to do whatever job it has. So trigeminal nerve is going and doing whatever job it has? Yes. And what is in addition it is doing? It is just carrying some fibers of the postganglionic fibers coming from some ganglia. So when you say that trigeminal nerve is carrying the postganglionic fiber coming from the ganglia, what is that relation called? That relation is called topographic relation. Topographic topography means location wise, anatomically. So location wise and anatomically, yes. You mean to say the anatomical nerve for now number 3, 7, 9, 10 is trigeminal. Yes. Remember TT. What is TT? Trigeminal is topographic. So TT, trigeminal nerve, is topographic. Yes. And it is carrying postganglionic fibers. Yes. And it is anatomically related or topographically related with the ganglia. Yes. Which are the functional nerve then? Functional nerves are now number 3, 7, 9, etc. So now number 3, 7, 9 are functional nerve because they are carrying the preganglionic fiber. They are the actual nerves which will be doing the function. Yes, but postganglionic fibers will be carried by branches of trigeminal, and that will be topographic nerve, anatomical nerve. This we'll discuss again. At this moment, just remember, the number 3, 7, 9, 10 and nervi irrigantes are functional nerve and carrying the preganglionic fibers towards the ganglia. Okay, what is the nucleus of third nerve, if you remember? Edinger-Westphal nucleus. So Edinger-Westphal nucleus is the parasympathetic nucleus for third nerve to control ciliary ganglion and 2 smooth muscles of the eyeball. Which 2 smooth muscles of eyeball? We'll draw a diagram and see. What about the superior inferior salivatory nucleus? If you remember, this is for 7th nerve, this is for 9th nerve. If 7th nerve has superior salivatory nucleus and the 9th nerve has inferior salivatory nucleus, which ganglia are you talking about? Actually, facial nerve has 2 ganglia. And what are the names? We draw a diagram and discuss, but they will be called as pterygopalatine ganglion and the submandible ganglion. And what is the submandible ganglion for facial nerve doing? Controlling some salivary gland. And what is the pterygopalatine ganglion for facial nerve doing? Supplying some lacrimal nasal palatine gland. Lacrimal nasal palatine gland. So this is something which we have to draw and discuss. What about the 9th nerve? 9th nerve has otic ganglion. You see here, 9th nerve is having otic ganglion to control the parotid salivary gland. So this is the inferior salivatory nucleus for 9th nerve having the otic ganglion to control the parotid salivary gland. Yes. And what is the 10th nerve having? Dorsal nucleus of vagus. And what is dorsal nucleus of vagus doing? It has several ganglia, multiple ganglia, some in the thorax, some in the abdomen. And what do? They will supply the viscera in the abdomen and the thorax also. So this is the diagram which we are supposed to draw. Let's do that, and it's here. You will be talking about nerve number 3, 7, 9 in the beginning, and then you can talk about 10th nerve also separately along with the nervi adiganti. So first you are focusing upon nerve number 3, 7, 9. Let's do that. You see, this is the brain, and that is the brain stem having 3 components. Let us enlarge it now. So that is the brain stem and having 3 components. You are enlarging it now? Yes. So you are telling this is the brain which is having the brain stem, and you are enlarging the brain stem now. Yes, this is going to be the midbrain, that is going to be the pons, and this is the medulla oblongata. And that is where we have the GVE system. What is that? GVE system. What is GVE system? G for general, and V for visceral, and E for the muscle. E for muscle means efferent. Yes, efferent means muscle. Muscle means efferent. So general visceral muscle. Are you talking about cardiac smooth muscle? Yes, cardiac muscle and the smooth muscle. Not only that, but we are also talking about the glands, because glands have smooth muscle. This is autonomic nervous system, parasympathetic system. So this is cardiac muscle and the smooth muscle of the gland. This is the secretomotor fibers. Yes. Parasympathetic system, autonomic nervous system, GVE system. So, do you remember which nuclei are under the GVE system? Which nucleus is for the third nerve? It is called as the Edinger-Westphal nucleus for the third nerve. And this Edinger-Westphal nucleus, which is in the upper midbrain, it is sending the preganglionic fiber now. Where is this preganglionic fiber going? To the ciliary ganglion. And where is the ciliary ganglion present? It is in the orbit. So you are telling that there is some ciliary ganglion in the orbit now. Who is carrying the preganglionic fiber? The preganglionic fiber is the functional nerve. And who is the functional nerve? That is the oculomotor nerve, number 3. So you're telling that Edinger-Westphal nucleus, which is a GVE neural column, is sending the preganglionic fiber from the upper midbrain. The preganglionic fiber carried by the oculomotor nerve to the ciliary ganglion in the orbit. And what is it controlling? The 2 smooth muscles, namely, they're in the eyeball. Their names are ciliaris muscle, and then there is a sphincter pupillae. What is sphincter pupillae doing? It is doing meiosis. Sphincter pupillae, meiosis for light reflex. Now, if you are telling that the ciliary ganglion is going to control 2 smooth muscles, one of them is ciliaris and other is sphincter pupillae. Sphincter pupillae in the eyeball is doing meiosis for light reflex. What is ciliaris for? Ciliaris. It is for accommodation reflex. How? By increasing the lens convexity. So you will increase the lens convexity and for accommodation reflex. Yes, that is for accommodation reflex. So ciliary ganglion is controlling ciliaris muscle to increase the lens convexity and help in accommodation reflex. Maybe it is the accommodation reflex or the light reflex. They are both controlled by Edinger-Westphal nucleus in the upper midbrain, which is parasympathetic nucleus controlling ciliary ganglion in the orbit, who is related to the 7th nerve then. The 7th nerve, yes. Maybe it is the 7th nerve or maybe it is the 9th nerve. You have superior salivatory nucleus and inferior salivatory nucleus in the lower pons. So 7th nerve, superior salivatory nucleus, and 9th nerve in inferior salivatory nucleus, both in lower pons. I thought that 9th nerve is having nucleus in the medulla. Yeah, that is correct. But I also told you that there can be overlapping neuron bodies. Of course, 9th nerve nuclei are expected to be in the medulla, but they can be overlapping. And some neurons have migrated into lower pons. Remember, maybe 9th nerve, but the inferior salivatory nucleus is in the lower pons. So superior salivatory nucleus for facial nerve, inferior salivatory nucleus for the glossopharyngeal nerve in the lower pons. Yes, what are they doing? They control salivary glands. Which salivary glands they are controlling? Actually, facial nerve, the superior salivatory nucleus, control 5 glands on the face. Which 5 glands on the face you are talking about? Let's discuss them. You will find now that the superior salivatory nucleus sending the preganglionic fiber to synapse into two ganglia. What are the two ganglia for the facial nerve? One is called as the pterygopalatine ganglion, and what is the other called? It is the submandible ganglion. So one is called as the pterygopalatine ganglion and other is called as the submandible ganglion. What are they doing? They will control some glands like LNP gland on the face. If you say pterygopalatine ganglion for the facial nerve is controlling LNP gland on the face, what is this LNP gland? What is that LNP gland? You will magnify and see. Draw the face. And when you draw the face, you draw the eyes and the nose and the mouth and discuss this is L. L for lacrimal gland and N for nasal gland and P for palatine gland. So you're telling LNP gland, the lacrimal, nasal, palatine gland are controlled by the pterygopalatine ganglion. Yes, it is the pterygopalatine ganglion. So pterygopalatine ganglion is controlling the L for lacrimal, N for nasal, P for palatine gland. What about the submandible ganglion? Submandible ganglion is going under the mandible, controlling gland under the mandible, under the tongue also, which is called submandible and sublingual salivary gland. So you are telling that there is some ganglion under the mandible. Yes, it is with the facial nerve. So facial nerve has a ganglion under the mandible, which is submandible ganglion, controlling some submandible salivary gland and sublingual salivary gland. Maybe submandible, sublingual salivary gland, they are under facial nerve. Facial nerve control 5 glands on the face using superior salivatory nucleus. So facial nerve is controlling 5 glands on the face using superior salivatory nucleus. 5 glands. And what about the ganglia? 2 ganglia. And what about the ninth nerve? Ninth nerve, if you say, let us discuss ninth nerve. Actually, ninth nerve is having inferior salivatory nucleus sending preganglionic fiber to the otic ganglion controlling the parotid salivary gland. Once again, which ganglion? That is the otic ganglion. So you are mentioning ninth nerve is having inferior salivatory nucleus in the lower pons, yes, and sending preganglionic fiber to the otic ganglion, right, and from the otic ganglion controlling the parotid salivary gland. I think this nerve number 3 or maybe 7 or maybe the 9th are functional nerves. Yes, they are. Now number 3, now number 7, now number 9, even now number 10 are functional nerve. And who is the topographic nerve? Remember, maybe this fiber, this fiber, this fiber, this fiber, they're all carried by trigeminal nerve, which is topographic, T and T. So topographic nerve is the trigeminal TT, yes, and it'll carry postganglionic fiber, postganglionic fiber, postganglionic fiber, and postganglionic fiber in the head neck region, yes, because the number 3, 7, 9 are preganglionic fibers, they are functional nerve. Even the 10th nerve is preganglionic fiber and functional nerve. That is all MCQs. Our discussion, our teaching, whatever we do is all MCQ based. Either the MCQ has already come and has a chance of repetition, or maybe it has not come yet, but it is predictive value that it will come in future, recent future. Okay. Can we discuss the 10th nerve then? Yes, 10th nerve. You see, 10th nerve will have a nucleus which is called dorsal nucleus of vagus. It is a parasympathetic nucleus and it is under the GVE system. So under the GVE system, you are having the dorsal nucleus of the vagus. What about the dorsal nucleus of vagus then? Parasympathetic nucleus. That we will draw a separate diagram, and let's do that. This is the diagram. For dorsal nucleus vagus, you have to draw a separate diagram along with the nervi erigantes there. So this is the diagram for thorax, yes, and abdomen, yes, and pelvis perineum, yes, not the perineum, the pelvis, pelvic viscera. So let's do that. And as you are doing that, you will find this is the brain and that is the spinal cord. If that is the brain and spinal cord, then where is the vagus nerve nucleus? In the medulla oblongata. It was called dorsal nucleus of vagus. So you're telling that in the brain there's a brainstem, there's a medulla oblongata having a dorsal nucleus of vagus? Yes. And vagus nerve is quite a long nerve, the longest cranial nerve. Now if you say vagus nerve is quite a long nerve, longest cranial nerve, is it white in color? Yes, it is white in color because it is preganglionic fiber and it is a functional nerve. The postganglionic fibers are very short length. Why? Because parasympathetic ganglia are close to the target organ. So it is the postganglionic fibers which are short length for parasympathetic system. Like which ganglia are you talking about? Maybe Auerbach's ganglia, Meissner ganglia in the GIT. So Auerbach's ganglia, Meissner ganglia in the GIT? Yes. Okay. So postganglionic fiber will be in the wall of the gut tube and very short fibers. They don't even have any names. No names. No names. Okay. Vagus nerve was coming to the thorax. What is it doing in the thorax? In the thorax, the vagus nerve is going to supply trachea and bronchus. Not only it will supply trachea and bronchus, it is also supplying the lungs. So supplying the trachea, bronchus and lungs now. Yes. What is it doing there to the trachea, bronchus? Vagus nerve is causing bronchoconstriction. It is reducing the lumen of the respiratory tube. So vagus nerve is causing bronchoconstriction, reducing the lumen. Yes. And it is also increasing the secretions. Asthma, you know. When you're talking about the asthma, which system is more powerful? Vagus is more powerful. Parasympathetic system is more powerful. Actually, it is hyper-responsive tracheobronchial tree. So in asthma, there is hyper-responsive tracheobronchial tree. And which nerve is more powerful? Vagus. What is it causing? Bronchoconstriction. And what will happen? Bronchi, wheezing. And what else will happen? There will be crepitations. Why crepitations? Because you are increasing the secretion. So in asthma, vagus nerve is more powerful, and vagus nerve causes bronchoconstriction and increased secretion. You can use some anticholinergic now. In asthma, yes. Which anticholinergic? You know, tell me. Ipratropium bromide. So you are talking about the ipratropium bromide, and it is some anticholinergic drug used in asthma? Yes, you can use it. Though in asthma you use bronchodilators also. Other way. Anyway, what is it doing to the heart? The vagus, yes. Vagus nerve on the heart is cardio-inhibitory. If you say it is cardio-inhibitory, it will reduce the 3 C's. What are the 3 C's it is reducing? Vagus nerve is cardio-inhibitory to the heart, and it will reduce the contractility of the heart and the conductivity of the heart and the chronicity of the heart. Now, if you say it is reducing the contractility, conductivity and chronicity of the heart, you mean to say it will cause bradycardia? Yes, it causes bradycardia. Vagus nerve can cause bradycardia. And what else it is causing? What will happen to RR interval in the ECG? RR interval in the ECG. Yes, if the vagus nerve is activated. RR interval. RR interval will be actually, see, it is bradycardia. So prolonged. It will be prolonged. So RR prolongation. Yes, in ECG. So there will be RR prolongation ECG because there is bradycardia. Yes. Okay. What is vagus nerve doing in the abdomen region? In the abdomen region, it is supplying the large intestine. And which part of large intestine it is supplying? See, this is cecum, this is appendix. This is ascending colon, transverse colon, descending colon, sigmoid colon, rectum, anal canal. What is that? Large intestine. What is in the large intestine? You see, this is the cecum and this is appendix. And ascending colon and transverse colon and descending colon and sigmoid colon and rectum, anal canal. Now, once you have told about the large intestine, can you tell me vagus nerve supplied till? Vagus nerve, yes. Vagus nerve supplied till the midgut. So, it will supply till the right 2/3 of transverse colon. So, till the right 2/3 of the transverse colon will be the vagus nerve. What is beyond that? Beyond that must be the next nerve. And who is the next nerve? Which nerves supply the splenic flexure and the rectum part of the hindgut? That will be the next set of nerve. Who is that? That must be the nervi erigentes, because vagus nerve supply the appendix, cecum and the ascending colon, right, 2/3 of transverse colon till the midgut. What is it doing there? Causing evacuation by increasing peristalsis, relaxing the sphincter, that is the parasympathetic evacuation. Remember, vagus nerve will supply till the kidney. Now, if you say vagus nerve supply till the kidney, it will also supply the upper ureter. But only upper ureter. Who will supply the lower ureter? If you say lower ureter, urinary bladder, urethra, then it must be the next set of nerve. And who is that? Vagus nerve can supply till the kidney and upper ureter. But if you are talking about the lower ureter or urinary bladder, then the next set of nerve, which is nervi erigentes. Let us talk about them now. So, this time you are talking about S234? Yes, S234. S234, sacral spinal segment, S234, which is nervi erigentes. And nervi erigentes are also called pelvic splanchnic nerve. They are called pelvic splanchnic nerve because they are supplying the pelvic viscera. Can you name some pelvic viscera? Yes, of course. This is urinary bladder and this is urethra. So, urinary bladder and urethra, yes. And then this is the uterus and that is the vagina. So uterus, vagina now, yes. And then this is the rectum and this is the anal canal. So that is rectum and anal canal. This is pelvic viscera, yes. Now when you say S234 nervi erigentes or pelvic splanchnic nerve are supplying the pelvic viscera, what do they do? What do they do? They increase the peristalsis and relax the sphincter. So there will be urination and there will be urination and there will be defecation. So you are telling there will be urination and defecation, bladder wobble evacuation? Yes. That is what they do. Okay, if you say so. You know, there is a boundary line. And below this boundary line this is pelvis and that is the perineum. If you say this is the pelvis and this is the perineum, which nerve is supplying the perineum? Perineum is the place where you have openings of the urethra, opening of the vagina and opening of the anal canal. So this is pelvic viscera in the pelvis, yes. And below that is perineum, yes. And what is perineum? Where you have the openings. Which opening you are talking about? Maybe urethra and vagina and the anal canal. So, who is supplying the perineum? That is somatic nervous system. And who is the somatic nerve here? Somatic nerve is actually the pudendal nerve. So remember, pudendal nerve is the nerve of the perineum and it is a somatic nerve. So this is the boundary line between somatic nervous system and autonomic nervous system. Yes. Above this line is autonomic nervous system, which is the nervi erigentes. And what do? They cause bladder bubble evacuation. And what if I want to hold the urine? What if I want to hold the fecal matter? If you want to hold the fecal matter or urine, then you need the pudendal nerve. Pudendal nerve controls somatic nervous system, the skeletal muscles. It will control the sphincters, urethra sphincter and the vagina sphincter and the anal sphincter. So, pudendal nerve, which is a somatic nervous system, nerve of the perineum, has to control skeletal muscles and can help you hold the urine using urethral sphincter. Hold the vaginal matter using vaginal sphincter, skeletal muscle sphincter. Hold the fecal matter, external anal sphincter. And what is the smooth muscles doing? Smooth muscles were under the autonomic nervous system and they will cause bladder wobble evacuation if you have activated the autonomic nervous system, nervi erigentes. This we will discuss later as well. At this moment, we are proceeding further. So as we are proceeding further, what are the details we need? Actually, you are getting a question now, GVE system. So, GVE system, I know. If you know, then tell me the answer. General visceral muscle. Yes, correct. Now, if you're telling this is the answer, you know, most of the skeletal muscles are GSC and some of them are SVE. Who is SVE? The pharyngeal arch muscles. Now, if you say pharyngeal arch muscles are special visceral muscles, SVE, most of the skeletal muscles are general somatic muscles. GSC means general somatic muscles. So, skeletal muscles are mostly GSC, general skeletal muscles, and some of the skeletal muscles could be SVE, the pharyngeal arch muscles, special visceral muscles. So, that is the answer. Yes, actually, this question is asking about autonomic nervous system. And because it is asking about autonomic nervous system, it has three factors. What are the three factors of autonomic nervous system? They are the smooth muscle, they are the cardiac muscle, and they are the secretomotor fiber, smooth muscle of the gland. So the answer remains choice number B. Yes, because it is GSC mostly, or maybe SVE sometime. So keep the answer as choice number B. What about this question? It is asking GVE again. If it is asking GVE again, I know the exception. If you know the exception, can you tell me also what is the answer? Okay, you have known Edinger-Westphal controlling two smooth muscles in the eyeball. You have known the lacrimatory nucleus, which is the upper part of the superior salivatory nucleus controlling lacrimal gland. So lacrimatory nucleus is a part of the superior salivatory nucleus, which is controlling lacrimal gland. Yes. Okay. Dorsal nucleus of vagus, which is a motor nucleus to control the cardiac muscle and smooth muscle. Cardiac muscle and smooth muscle. So, are you trying to say that the answer is choice number D? Yes. Why? Because you know LR6. What is LR6? LR6 is the formula of eyeball. Lateral rectus supplied by sixth nerve. If you remember, we have discussed eyeball muscle and tongue muscles are skeletal muscles and they do not develop in the pharyngeal arches. The eyeball and tongue muscles are skeletal muscles, do not develop in the pharyngeal arches, so belong to GSE. They are not the GVE. So you want to say lateral rectus is GSE. Yes, G for general, S for somatic, E for muscle, general somatic muscle. So the answer is choice number D. Yes, it is. Because it is GSE. It is not GVE. Okay, fine. We'll keep our answer as choice number D then. And now we are comparing the parasympathetic with sympathetic nervous system. Actually, parasympathetic system is activated when we are resting and digesting. So rest and digest is parasympathetic system. Yes. It is anabolic in nature. What is anabolic? Anabolic means you will conserve energy. Conserve energy. So you are conserving energy now. Yes. Anabolic. So, parasympathetic system is anabolic and it is to conserve the energy, rest and digest. And what is the sympathetic system for? It is antagonistic. What is antagonistic? Fight or flight reaction. Now, obviously, you are not going to fight with such an animal. See what is happening. This animal has a piece of pent on its horn, and if you don't run, then after some time gluteus maximus will be there. You want gluteus maximus here? No, then run. See, whether you are choosing to fight or take a flight away from the emergency, this is always emergency situation, and emergency lasts for a short duration. For it is a short burst of activity and it is catabolic in nature. If you say it is catabolic in nature and it is short burst of energy, sympathetic system? Yes, sympathetic system is fight, flight reaction, fright also I can add. When you are frightened, it is activated. So when we are frightened, what will happen? What are the signs of fright? You will find you are sleeping in the house alone, 3 a.m. in the morning. Somebody knocking at the door. You open the door and suddenly a man stands in front of you with some mask which is dangerous. You know, your friend is trying to frighten you. What will happen? First of all, you are in sleep. You woke up and suddenly. See, what happens is the sympathetic system was activated. Your eyes will be wide open, dilated, and your skin will go cold in the periphery. Why cold in the periphery? Vasoconstriction. All the blood is being shunted towards your heart in emergency, brain also. So, हिंदी में आंखें फटी की फटी रह गई और हाथ पांव ठंडे हो गए. So, हाथ पांव ठंडे हो गए और आंखें फटी की फटी रह गई. The pupils are dilated and there's vasoconstriction at the periphery. So that is sympathetic system, yes. Just to have some idea. Fright. We have taken one table from Harrison Medicine and just want to compare the two systems. And here we have already described the parasympathetic system. Can you tell me again what was happening by vagus nerve? Vagus nerve is causing bradycardia. And what else it is causing? It is causing bladder wobble evacuation. How the vagus nerve is causing bladder wobble evacuation? To cause the bladder wobble evacuation, I'll increase the peristalsis and relax the sphincter. Vagus nerve is also causing bronchoconstriction. We have told that in asthma, there is bronchoconstriction to the lung. So you were using some ipratropium bromide as anticholinergic drug. Understand, parasympathetic system is causing meiosis. If it is causing meiosis, when you're resting and digesting, you feel sleepy, meiosis. And I told you, nervii cause erection. Nervii is a parasympathetic system for erection, and most of the glands are under parasympathetic cholinergic pathway. If you say most of the glands are under parasympathetic cholinergic pathway, then the glands will increase the secretion. Do you know about OP poisoning? Tell me the clinical features of OP poison. OP poison, some of them, they are increasing the parasympathetic activity, cholinergic system. So in OP poisoning, when the parasympathetic system is activated, there's more of acetylcholine in the body. Observe your patient now. You will find your patient is having bradycardia and your patient is having bladder wobble evacuation. He has defecated and urinated. So in OP poison, there is more of acetylcholine in the body. Yes, parasympathetic system is more powerful, and there is bradycardia, low pulse, and there is defecation, urination, and you will find difficulty breathing because there is bronchoconstriction. He is having wheezing and also lot of secretions. Actually, you will find there is a lot of tears coming out and nasal secretion, salivation, throat congestion, chest congestion. Actually, they die because of pulmonary edema. They die because of pulmonary edema. You have to give respiratory support and also start injecting intravenous atropine, anticholinergic. If you want to save your patient of OP poison, you have to inject intravenous atropine. Some patient may respond. Anticholinergic. So what else your patient was having? I saw his pupil were having meiosis. So these are all the features of parasympathetic activity. Vagus nerve became more powerful. Nervii irrigantes became more powerful in OP poison. There is a lot of acetylcholine in the body. So you can use anticholinergic drugs like atropine. Now, what about the sympathetic system? Fright and fight and flight. So if it is fight and flight, then what? Tachycardia, palpitation. See, if some animal is running after you, you will have tachycardia, palpitation. And remember, sympathetic system is for storage by reducing peristalsis. If you say sympathetic system is for storage by reducing the peristalsis, what is parasympathetic system for? Remember, sympathetic system is for storage by reducing peristalsis. Parasympathetic was evacuatory. It was evacuatory. And what is the sympathetic system doing to the lung? You use the salbutamol, beta-2 agonist in asthma, isn't it? Sympathomimetic. So you are telling that the sympathetic system is bronchodilatory, beta-2 agonist, sympathomimetic. I will use the salbutamol in asthma. Yes. Sympathetic system is bronchodilator. And what is it doing to the pupil? Pupil, remember, if you are talking about dilator pupillae, it is adrenergic muscle for mydriasis. If you're talking about dilator pupillae, it is adrenergic muscle. For mydriasis, it is sympathetic adrenergic muscle. But if you're talking about the sphincter pupillae, then it is cholinergic muscle. It is parasympathetic cholinergic muscle, myosis. So remember, sphincter pupillae is a cholinergic muscle for myosis, whereas dilator pupillae is a sympathetic adrenergic muscle for mydriasis. And what is happening to the sexual function? If it is nervi irrigantes, they were causing erection, but if it is sympathetic system, it is working for ejaculation. So sympathetic system work for ejaculation, yes, and the parasympathetic for erection, right? And then you remember that most of the glands are under parasympathetic system, cholinergic system. Maybe sweat gland is an exception because it is under sympathetic system, but still, despite the fact that sweat gland is under sympathetic system, mostly uses acetylcholine. There are very few sweat glands which are sympathetic adrenergic. Most of the sweat glands are sympathetic cholinergic. So, mostly glands use acetylcholine. Mostly they are under parasympathetic system. And maybe you are telling that sweat gland is sympathetic, but most of the sweat gland are sympathetic cholinergic. Remember that. Now, we want to talk about the sympathetic nervous system, some details. And as you move on to sympathetic nervous system, you will find this diagram. We are talking about the thoracolumbar flow. Thoracolumbar flow. So when you're talking about the thoracolumbar flow, sympathetic flow, what about that? See, we will magnify this area and discuss. You have some neurons in the CNS, starting at T1 spinal segment and ending at L2 spinal segment, thoracolumbar flow. Sympathetic neurons are present in the lateral horn cells of the spinal cord. When you say sympathetic neurons are present in the lateral horn cells of the spinal cord, where do they begin to appear? Thoracic 1, and there will be 12 thoracic segment and upper 2 lumbar. 12 plus 2, 14 spinal segments. So there are 12 plus 2, 14 spinal segments. Yes. There you have the sympathetic neuron thoracolumbar flow. Yes. Okay. If you have the central nervous system lateral horn cells having sympathetic neuron, then where is the peripheral nervous system? Ganglia. Which ganglia? You see, this is sympathetic ganglia now. There are some sympathetic ganglia which are on the side of vertebra. We call them as the paravertebral ganglia. And there are some ganglia in front of the vertebra which are called as prevertebral ganglia. They are in the midline. These are in the midline. So you have some midline ganglia also, which is prevertebral ganglia in front of the vertebra. Yes, they are also pre-aortic. They are in front of aorta. Their names are according to branches of aorta. Like aorta gave celiac trunk, you have celiac ganglion. Aorta gave superior mesenteric artery, you have superior mesenteric ganglion. Aorta gave inferior mesenteric artery, you have inferior mesenteric ganglion. And they control the viscera. You are trying to say there is CNS PNS. Yes. And where is CNS? That is the spinal cord. And where is the PNS? Ganglia. What ganglia? There is the paravertebral ganglia and there are the prevertebral ganglia. Prevertebral ganglia are actually in front of the vertebra, in front of the aorta. Their names are according to the branches of the aorta and they control viscera. Then what is paravertebral doing? Paravertebral, they control the skin effectors, like you have sweat gland. So you want to control sweat gland, use the paravertebral ganglia. Now understand, there's a preganglionic fiber which will be white ramus communicantes, letting it pass. Why would you say that preganglionic fiber is passing white ramus communicantes? Because they are myelinated fibers, white. And what are the postganglionic, this red color? Postganglionic, that red color is gray ramus communicantes because they are non-myelinated. You are trying to say that the central nervous system, the green color fiber is myelinated fiber using the white ramus communicantes. Yes. And then you have synapse here and the postganglionic fibers are coming, which is gray ramus communicantes. Yes. They are non-myelinated fibers controlling the skin effector now. But then remember some of the neurons, nerves, what they do is they are bypassing the paravertebral ganglia so that they can synapse in the prevertebral ganglia. If you say some of the fibers are bypassing the paravertebral ganglia, to synapse in the prevertebral ganglia. These fibers are called splanchnic nerve. Like this is the greater splanchnic nerve. There will be a lesser splanchnic nerve, and there will be a least splanchnic nerve, lumbar splanchnic nerve. This we will be discussing in the abdomen region. So you are telling that there are some splanchnic nerve, namely the greater splanchnic nerve and the lesser splanchnic nerve and the least splanchnic nerve and the lumbar splanchnic nerve. Yes, and splanchnic nerves are preganglionic fiber. How come they are preganglionic fiber? Because they have bypassed the paravertebral ganglia to synapse in the prevertebral ganglia. This you have to remember. Now, if you say so, fine. Let us look at the further details. And this is the diagram. Understand, sympathetic system is thoracolumbar flow and restricted to the 12th thoracic and upper to lumbar segment. And this is CNS. And where is PNS? PNS is two sets of ganglia. What are the two sets of ganglia? If they are on the side of vertebra, you say paravertebral. And if they are in front of the vertebra, you say prevertebral ganglia. Paravertebral and prevertebral ganglia, sympathetic ganglia. Yes, actually, paravertebral ganglia are making the sympathetic chain. They are on the side of vertebra, paravertebral ganglia making sympathetic chain. And they are going to control skin effectors. That could be the sweat gland. Then what about the other set of ganglia? They are called as the prevertebral ganglia. They are in front of the vertebra. They are in the midline. They are also pre-aortic ganglia in front of the aorta. Names are according to branches of aorta. Could be celiac artery, celiac ganglion, superior mesenteric artery, superior mesenteric ganglion, inferior mesenteric artery, inferior mesenteric ganglion. They control pelvic viscera, say thoracic viscera, abdominal viscera, etc. Even the pelvic viscera, of course. So, like that, yes. Okay. We need more information now. Let us talk about the skin effectors then. Let us control the skin. This is paravertebral ganglia now going to control the skin effectors. How? You see, there will be a preganglionic fiber coming from the CNS and it will be synapsing in the PNS, which is the paravertebral ganglia, which will then send the postganglionic fiber to supply the skin effector. This is what we are going to discuss now. The grey ramus communicante, yes. White ramus communicante, yes. The grey ramus communicante and white ramus communicante, that is what we want to discuss. And you will understand, this is the spinal cord and there is a ventral root and dorsal root. If you say this is the ventral root and that is the dorsal root, what are they joining to form? They join to form a spinal nerve. And what is the spinal nerve doing? It is connected to the sympathetic ganglia by two communicantes, which are called as white ramus communicante and grey ramus communicantes. Tell again what is happening. Actually, there is the spinal cord having ventral ramus, ventral root and dorsal root. If the spinal cord is having ventral root, dorsal root, what are they joining to form? They form the spinal nerve. And what is the spinal nerve doing? It is connected to the sympathetic ganglia with the help of ramus. Remember, distal is the white ramus communicante and proximal is the grey ramus communicante. So proximal is grey ramus communicante and distal is the grey ramus communicante. What are they carrying? What they are carrying, let us draw a diagram and discuss. Let's draw the diagram. Our diagram will tell us about the paravertebral ganglia, giving us the preganglionic fiber passing the white ramus communicante. And then you will see that there is a grey ramus communicantes also. This is the diagram. We have taken a transverse section of the spinal cord now. There's the transverse section of spinal cord. This is the lateral horn cell and giving some fiber in the ventral root of spinal cord and reaching the spinal nerve and using the grey ramus, white ramus communicante to control sweat gland in the skin. Let's make the diagram. As you're making the diagram, what did you do? I have taken a transverse section of spinal cord, which is now showing the H-shaped gray matter. If that is the H-shaped gray matter, what is there in the lateral horn cells? What is there in the lateral horn cells is the sympathetic neuron, parasympathetic neuron. This time I am talking about the sympathetic nervous system. So this is a sympathetic neuron. Now you got a sympathetic neuron in the lateral horn cell. Then where is the preganglionic fiber? That we will discuss. First you show that this is the structures we are talking about. What are the structures you are talking about? We are talking about the ventral root of spinal cord, the dorsal root of spinal cord, and then this is joining to form the spinal nerve, and spinal nerve is connected to the sympathetic ganglia with the help of a distal white ramus communicante, proximal gray ramus communicante. So you're telling this is the ventral root of the spinal cord, dorsal root of the spinal cord, and joining to form spinal nerve, which is connected to the sympathetic ganglia. How? By a distal white ramus communicante and a proximal gray ramus communicante. Now, once you have drawn that, let us supply the skin, sweat gland. So, if you want to supply the skin, the sweat gland, how will you supply the skin, the sweat gland? There will be one preganglionic fiber coming from lateral horn cell, passing the ventral root, entering spinal nerve, and passing the distal white ramus communicantes. Why white ramus? Because it is myelinated fiber. This is preganglionic fiber. So, you are telling that lateral horn cell is a sympathetic neuron here? Yes. And sending the preganglionic fiber by the ventral root of the spinal cord, yes. Entering the spinal nerve, yes. Exiting spinal nerve using the white ramus communicante, and then it is white ramus because it is myelinated fiber. Preganglionic fibers are myelinated fiber. Then what is it doing? It is synapsing in the sympathetic ganglia. This time it was paravertebral ganglia. Why would you say it is paravertebral ganglia? Because it is on the side of the vertebra. Paravertebral ganglia making the sympathetic chain. So it is sympathetic ganglia making sympathetic chain. Yes. Okay. So if this is a neuron in the paravertebral ganglia, what is it doing? It is receiving the synapse, and postganglionic fiber will re-enter the spinal nerve and supply the gland. You mean to say postganglionic fiber is entering the spinal nerve using the gray ramus. Why gray ramus? Because postganglionic fibers are non-myelinated fibers, so gray ramus communicantes. So you're telling this is postganglionic fiber which is non-myelinated fiber, so gray ramus communicantes? Yes, entering the spinal nerve and going to supply the sweat gland. This is what we wanted to know, and it's done. So this is what you wanted to know. Yes. Okay, fine. Let us move on to the next thing, which is prevertebral ganglia or pre-aortic ganglia. What about them? What do? They supply the viscera. Can you tell me how do they supply the viscera then? Yeah, okay, let us see how do they supply the viscera. And you will find there is some preganglionic fiber like greater splanchnic nerve. Remember, the greater splanchnic nerve is coming from the CNS, so it must be white in color. They are myelinated fiber. They use the white ramus communicantes. So this is greater splanchnic nerve and it is white ramus communicantes it is using, yes, and it is bypassing the sympathetic chain to synapse in the midline ganglia, which are the prevertebral ganglia. Like which one? Like celiac ganglion. Celiac ganglion. Now, if it is synapsing in the celiac ganglion, what is the celiac ganglion doing? Celiac ganglion is going to control the foregut derivative, like the stomach. So you are talking about this greater splanchnic nerve here. Yes. Where is coming from? Greater splanchnic nerve. Yes. It is coming from T5 to T9. Spinal cord. T5 to T9 spinal cord. So it is T5 to T9. It has 5 root values starting with 5. Greater splanchnic nerve has 5 root values starting with number 5. The T5 to 9. Greater splanchnic nerve is synapsing in the celiac ganglion and is controlling the foregut like the stomach. And what it will do to the stomach by celiac ganglion? Celiac ganglion is for the foregut, and it will be sympathetic system, so it will increase the peristalsis. But if you are increasing the peristalsis, it is sympathetic. It will reduce actually. It is reducing, not increasing. So sympathetic system is for reducing peristalsis. But if you are telling this is a sympathetic system which will reduce the peristalsis, there will be retention. And when there is a retention, there will be retention pain. Who will carry the retention pain? Because there's stomach distension pain. Now, who will carry that pain? Understand. Sympathetic system is reducing the peristalsis of stomach, and there will be a stomach distension pain. Who will carry that pain? The same nerve. Who is that? Greater splanchnic nerve. You are telling that when there was greater splanchnic nerve causing reduced peristalsis, stomach distension, the pain was also carried by the same nerve. Is it a sensory nerve also? Yes, it is sensory motor both. Not only it is GVE, but it is also GVA. What is GVE, GVA? G for general, V for visceral, and E for muscle. Which muscle? The smooth muscle of the stomach. So G for general and V for visceral and E for muscle, the smooth muscle of the stomach. What is it doing? Reducing the peristalsis, and there was a pain. That pain is GVA. What is G for? The general. What is V for? The visceral. And what is A for? Sensation. General visceral sensation. So general visceral sensation is also carried by same nerve, greater splanchnic nerve. Yes, it is a sensory motor nerve. Not only it is GVE, but it is also GVA. Now, once you have that kind of orientation, you will draw this diagram. Let's draw the diagram ourselves. So, you will talk about the sweat gland on one side and the stomach on the other side. This is our revision. So, as you are revising, you will tell this is the brain and this is the spinal cord. And T1 spinal cord and L2 spinal cord is thoracolumbar flow. That is where we have the sympathetic neurons present in the lateral horn cells. See, if that is the brain and this is the spinal cord and there is a thoracolumbar flow, there are 14 segments, 12 thoracic and 2 lumbar, giving you sympathetic neuron. But this is CNS, you need a PNS now. And when you say PNS, you will find that this is sympathetic chain, which is on the sides. If you say these are the sympathetic chain on the sides, then there is sympathetic ganglia, sympathetic ganglia, sympathetic ganglia. And these sympathetic ganglia are called as the paravertebral ganglia because they are on the side of the vertebra. So these are paravertebral ganglia because they are the side of the vertebra. Yes. What do they do? They are in the sympathetic chain and they are controlling the skin effectors. Like what? Like they are controlling the sweat gland. So you are mentioning that there are some sympathetic ganglia in the sympathetic chain and they are going to control the sweat gland in the skin. Can I see some pathway regarding that? Yes, of course. Let's do that. There will be a neuron from the CNS synapsing here and a neuron from the PNS innervating there. But the neuron which comes from the CNS is passing white ramus communicantes and the one which is passing there is gray ramus communicantes. Why so? Because the neuron from the CNS is the myelinator fiber. Preganglionic fibers are myelinator fibers. They'll be using the white ramus communicantes and the postganglionic fibers are non-myelinator fibers and they'll be using the gray ramus communicantes. And supply the sweat gland in the skin. Increase the secretion. Sympathetic system increases sweating. When you are frightened, when you're fighting or running away from fight, you're sweating like anything, isn't it? And what about the other system where you said some prevertebral ganglia are there? Yes, they are. They are in the midline, but we are showing them here. So these are some midline ganglia, but you are showing there. Why not here? Because just to prevent the overlapping, we are picking up from here and putting them there. So these are basically prevertebral ganglia. They are also pre-aortic ganglia and they are in the midline. But you have kept them on one side just to avoid the overlapping and confusion of structures. Okay, if they are in the midline and they are prevertebral or pre-aortic ganglia, what are the names? Names are according to the branches of the aorta. If you are having a ganglion around the celiac artery, you say celiac ganglion. Superior mesenteric artery, superior mesenteric ganglion. Inferior mesenteric artery, inferior mesenteric ganglion. This will be controlling the foregut, that is controlling the midgut, and this is controlling the hindgut because the arteries are accordingly doing the same. So you are telling that there are some midline ganglia, prevertebral, pre-aortic ganglia, the celiac ganglion for foregut derivatives. Yes. And superior mesenteric ganglion for midgut derivative. Yes. And inferior mesenteric ganglion for hindgut derivative. Yes. And supply the stomach then. If you want to supply the stomach, then it is foregut derivative. It will be supplied like this. Remember, the postganglionic fibers are carried by the branches of celiac artery. The postganglionic fibers will be carried by the branches of celiac artery. Now, if the branches of celiac artery carry postganglionic fiber, then who was carrying the preganglionic fiber? That is, nerve of the foregut, having 5 root value. What is this nerve of the foregut having phi root value? If you remember T5 to 9, greater splanchnic nerve. So T5 to 9, greater splanchnic nerve. Yes. Bypassing the sympathetic chain and synapsing there. You're telling this is greater splanchnic nerve. Yes. You see, this is phi root value of the spinal cord, which is T1, T5 to 9. So T5 to 9, greater splanchnic nerve having phi root value starting with thoracic phi is not synapsing in the paravertebral ganglia. They are bypassing the paravertebral ganglia. Now this greater splanchnic nerve, which ramus it will be using? Of course, white ramus communicante. Why white ramus? Because it is preganglionic fiber. So it is preganglionic fiber, myelinated fiber from the CNS, yes. So using the white ramus communicantes, yes, and then synapsing in the celiac ganglion and controlling the stomach. What it will do to the stomach? It will reduce the peristalsis. But if it will reduce the peristalsis of the stomach, then there will be stomach distension pain. Who will carry that stomach distension pain? If you are talking about the stomach distension pain, then that pain is also carried by the same nerve. Same nerve. You are telling that this nerve is then mixed nerve? Yes, it is mixed nerve, in fact. So you are telling that when we reduce the sympathetic system is working for reducing peristalsis and there was a stomach distension pain, that distension pain was carried by same nerve. Yes, same pathway. And this pain is now passing through greater splanchnic nerve. Yes, so it is a mixed nerve, right? And it is not only GVE, but it is also GVA. It is not only GVE, but it is also GVA. Let us discuss this again by taking a transverse section of spinal cord here. So we will take a transverse section of spinal cord here to discuss the greater splanchnic nerve. Yes, the splanchnic nerves basically. Some questions are coming, so we have to be careful about them. See, we have told there is a lateral horn cell giving a sympathetic neuron, and the preganglionic fiber are using the ventral root and enter the spinal nerve and exit the spinal nerve, passing distal white ramus, and then they bypass the sympathetic chain so that they can synapse in the prevertebral ganglia, which could be celiac ganglion, to control the stomach, the effector. And if the effector is having pain, then it is the same pathway it will use. But then remember, pain pathway which will come to the peripheral ganglion and will be entering the spinal nerve will be using the dorsal root to enter the spinal cord. This is the diagram which we are supposed to draw now. Let's draw the diagram. So we want to draw this diagram now. Yes, transverse section of spinal cord. Yes, the H-shaped gray matter, right? And the lateral horn cell. Yes, what is there in the lateral horn cell? This could be a sympathetic neuron, this could be a parasympathetic neuron, but this time it is sympathetic. Lateral horn cell could be a sympathetic or parasympathetic neuron, but this time it is sympathetic. What is the sympathetic neuron doing? Let's see what is it doing. But first you complete the diagram. There will be a ventral root and there is a dorsal root. They join to form the spinal nerve, which is connected to the vertebral ganglia, paravertebral ganglia. And there are some ganglia in front of the vertebra also. Prevertebral ganglia. Yes, this is prevertebral ganglia, which is sympathetic ganglia, and that is here celiac ganglion. Why celiac ganglion you are talking about? Because I want to control the stomach effector. And what is this? This is paravertebral ganglia, which is to control the skin effectors. Okay, if you say so. Tell about the stomach. If you want to talk about the stomach, then you have to understand there is a preganglionic fiber passing the ventral root of the spinal cord, and then using the distal white ramus and bypassing the paravertebral ganglia to synapse in the prevertebral ganglia. What is this? This is ventral root, that is dorsal root of the spinal cord. So this is the ventral root and that is the dorsal root of spinal cord. What is this? This is the spinal nerve. And what is this distal? Distal is the white ramus communicante. So you're telling that there is some sympathetic neuron in the lateral horn cell. Yes. And passing through the ventral root of the spinal cord. Yes. And to the spinal nerve. Yes. And then exiting the spinal nerve using distal white ramus communicantes. Yes, and not synapsing in the paravertebral ganglia. No, bypassing the paravertebral ganglia because it has to synapse in the prevertebral ganglia, which could be the celiac ganglion. These nerves are called as splanchnic nerves. Remember, splanchnic means visceral, so they are visceral nerves. They supply the viscera. Which splanchnic nerve you are talking about here? I'm talking about the greater splanchnic nerve right now. So the nerves which appear to come from the sympathetic chain without synapsing, they are splanchnic nerves. Yes, splanchnic means visceral. They have to supply viscera. And this splanchnic nerve is greater splanchnic nerve. Yes. Where is it synapsing? In the celiac ganglion. And who is carrying the postganglionic fiber? The branches of the celiac artery. If the branches of the celiac artery will carry the postganglionic fiber, what they will do to the stomach? They will reduce the peristalsis of stomach. But when you reduce the peristalsis of stomach, there will be stomach distension. And who will carry the stomach distension pain? That stomach distension pain is carried by same pathway. But then you have to understand it is using the dorsal root ganglion. Actually, there is a dorsal root ganglion carrying the pain of the stomach. In fact, it is a dorsal root ganglion is having two processes. One is central process going to the central nervous system, spinal cord, and there's a peripheral process. That peripheral process is going to carry pain of the stomach. You're telling that there's a dorsal root ganglion? Yes, it is pseudo-unipolar neuron. Pseudo-unipolar neuron. So there is some pseudo-unipolar neuron. Yes, it appears to be unipolar, but it has two processes. So you're telling that dorsal root ganglion in the spinal cord is pseudo-unipolar, means it is not unipolar? No, it is appearing unipolar. It is not unipolar. It has two processes. What are the two processes? One is going to the CNS, carrying pain here, but the other is peripheral process. That peripheral process was in the dorsal root, in the spinal nerve, and in the white ramus communicante, and in the splanchnic nerve, and in the around the blood vessels also. You mean to say when there was a stomach distension pain, the pain fibers were passing along the blood vessels? Yes. Along the splanchnic nerve? Yes. And along the white ramus communicantes? Yes. And the spinal nerve? Yes. And the dorsal root? Yes. And then the spinal cord, where it will be synapsing? You know, it will be synapsing in the second order neuron, which will send a pathway which is called as lateral spinothalamic tract, if you remember. Carrying the pain of the stomach contralaterally. Carrying the pain of the stomach contralaterally, lateral spinothalamic tract. Remember that. So, this is the information you wanted to know. Understand, greater splanchnic nerve is GVE and it is also GVA. It's a mixed nerve. It is a mixed nerve. This nerve is a sensory motor nerve. It is not only GVE, but it is also GVA. This is what we wanted to know, and it's done. Now, once this is also taken care of, let's deal with one question. One question is asking, this greater splanchnic nerve is passing which ramus communicante? The white ramus or great ramus? We already told. White ramus communicante. Why it is passing white ramus communicante? Because it is coming from CNS. It is preganglionic fiber, white myelinated fiber. Now the question is asking, this postganglionic fiber, which is non-myelinated fiber, is carried by? It is carried by the branches of the celiac artery to the stomach. So it is carried by branches of celiac artery to some sympathetic plexus around the artery. Yes, there is some sympathetic plexus around the artery. It is gray in color. Postganglionic, gray in color. One of the question is asking, greater splanchnic nerve is short in length or long in length? This is preganglionic fiber. It must be short in length because this is sympathetic system. So preganglionic fiber short in length, sympathetic system? Yes. Why? Because the sympathetic ganglia are close to CNS. If you say sympathetic ganglia are close to the CNS, the preganglionic fiber will be short length and the postganglionic fiber will be long length fiber. So postganglionic fiber will be long length fiber and the preganglionic fiber will be short length fiber. Yes, that is what we already have known because these ganglia are close to the CNS. Maybe it is paravertebral ganglia, which is close to CNS, or maybe the prevertebral ganglia that are close to CNS. Now, there's a question asking, how many preganglionic sympathetic fibers are there? How many preganglionic sympathetic fibers? Yes. Then I have 12 thoracic and 2 lumbar on each side. If you say 12 thoracic and 2 lumbar on each side, you mean to say 12 plus 2, 14 on right side and 14 on left side? Yes, 14 plus 14, 28. White ramus communicantes. So you are telling that there are 28 white ramus communicantes? Yes. Approximately. So there are 12 thoracic and 2 lumbar. Yes. How many postganglionic fibers are there? It is difficult to count. Postganglionic fibers are difficult to count, but then you can have some brief idea. 1:30 is the relation. 1:30 means one preganglionic fiber is synapsing with 30 postganglionic fibers. As many as 30. It can be less than that, but as many as 30. So how does it do that? Actually, it may be synapsing at the same level, or it may be ascending up to synapse at a higher level, or it may be descending down to synapse at a lower level. So it will supply the full body, maybe synapsing same level or ascend up to synapse at a higher level, or maybe it will descend down to synapse at a lower level. So number of postganglionic are more. Yes, maybe 30 times preganglionic. That is what we wanted to know here. Now, what we talk about is Horner syndrome. And there's a question asking, actually not one, there are many questions appearing on Horner syndrome. One of that is, Horner syndrome, what is not seen? And they have mentioned that it is cavernous sinus pathology, which could be internal carotid artery dissection inside the cavernous sinus. It is given by Harrison medicine. So there is some internal carotid artery dissection inside the cavernous sinus pathology. Yes, actually around that I have T1 sympathetic plexus, and that T1 sympathetic plexus might be compromised. Now if you say there is some T1 sympathetic plexus around the internal carotid artery is compromised, that will lead to Horner syndrome. Yes. Okay, then what is not seen? What is not seen? Yes. Anhidrosis. Why? Anhidrosis is seen in Horner syndrome. Yeah, but not in this case. This is third order neuron injury. So if it is third order neuron injury, it will not present with the loss of sweating? No. Explain why? Explain why? If it is third order neuron injury, why not there is loss of sweating? Let's discuss that. But remember, if somebody asks you, tell me the 2 clinical features of Horner syndrome, you should always answer. This question has already come. Tell me the 2 clinical features of Horner syndrome. What are they? Ptosis and meiosis. This is always your first answer. Anhidrosis may or may not be there. So anhidrosis may or may not be there. Yes. Can you explain this? Yes, we'll do that. Now, let us look at the statement by Harrison medicine, 19th edition as well as 20th edition. I have checked the 20th also. It's the same statement. So what is the statement? It's a triad. Triad of what? Triad of meiosis, ptosis and anhidrosis, but not necessarily all the time. You may not have anhidrosis. Like in this patient, there was no anhidrosis. So tell me, what are the 2 clinical features of Horner syndrome then? They are meiosis and ptosis. Always answer meiosis, ptosis, because anhidrosis may or may not be there. Now, we got 3 patients. According to Harrison, there are 3 patients we have to discuss, and they are, number 1, there was a Wallenberg syndrome leading to Horner syndrome on the same side. There's a Wallenberg syndrome leading to Horner syndrome on the same side. And then there is an internal carotid artery dissection leading to Horner syndrome on the same side. Wherever the dissection was, internal carotid artery dissection and Horner syndrome same side. And then there is some Pancoast tumor, apical lung cancer. Pancoast tumor, apical lung cancer leading to Horner syndrome same side. These are 3 patients which we have to discuss now. See, this is one baby with right-sided Horner syndrome. If you say this is a baby with right-sided Horner syndrome, what are the clinical features of Horner syndrome then? Actually, there is, you can see yourself now, this is ptosis, partial ptosis. Compare the eyelids. So as you're comparing the eyelid, this side you have partial ptosis. Yes, partial ptosis. Due to paralysis of a muscle which is called as the superior tarsal muscle, part of the Miller muscle. So there is some superior tarsal muscle, part of the Miller muscle which is not working. Yeah, because of that, upper eyelid elevation is compromised, partial ptosis. Superior tarsal muscle, part of Miller not working. Why? Because it is supplied by T1 sympathetic fibers which have been compromised. So it is supplied by T1 sympathetic fibers which have been compromised. Horner syndrome? Yes. What else is there? What else you want to see? Then you will find there is what? You compare the pupil. Compare the pupil. As you're comparing the pupil, you will find that here you are having this side, whatever the affected side of the Horner, meiosis. Why would I have meiosis? Why would I have meiosis? There is meiosis because sphincter pupillae has become more powerful. But why the sphincter pupillae has become more powerful? Because dilator pupil is paralyzed. Why the dilator pupil is paralyzed? Because dilator pupil is supplied by T1 sympathetic fibers. So T1 sympathetic fibers supply dilator pupillae. Yes, they are gone. So sphincter pupillae become more powerful, leading to meiosis. What is the third thing? Third thing, there is enothelmos. What is that? Enothelmos. If you say it is enothelmos, why there is enothelmos? Because of the paralysis of orbitalis muscle. There is one orbitalis muscle in the orbit under control of T1 sympathetic fiber. So T1 sympathetic fiber will be controlling some orbitalis muscle, the muscle of orbit. What is the normal job of orbitalis? Orbitalis is actually push the eyeball out of socket. And what if it is not working? Then it will go back into socket, which is called enothelmos. So telling that orbitalis muscle is in the orbit, yes, and push the eyeball out of socket normally, yes. And if it is paralyzed, then it will not push the eyeball out of socket, and eyeball will go back into socket. Yes, sunken eyeball, enothelmos. So there is injury of right side, yes, right Horner syndrome, and the right side at T1 sympathetic fibers compromised, yes. Three muscles compromised, yes. Name. Number one, superior tarsal muscle, part of Miller, leading to partial ptosis. Number two, paralysis of sphincter pupillae. So dilator pupillae became more powerful. No, dilator pupillae was paralyzed, sphincter pupillae became more powerful, leading to meiosis, because it is the dilator pupillae which is supplied by the T1 sympathetic fibers. So as you say, dilator pupillae is supplied by T1 sympathetic fiber. If T1 sympathetic fiber is gone in Horner syndrome, then sphincter pupillae became more powerful, leading to meiosis. And what was the number 3 muscle which is compromised? It is orbitalis. If orbitalis is compromised, number 3, there was enothelmos. What else is there in Horner syndrome? Nasal congestion. Why there is nasal congestion? Because vasodilation. Why there is vasodilation? So you see, there is vasodilation not only in the nose but skin also, conjunctiva also. The skin will become red color. Conjunctiva is red color. Why the skin is red color, conjunctiva red color on the right side of the face? Right side of the face, there is red skin, red conjunctiva and nasal congestion because of vasodilation. But why there is vasodilation? Hyperemia. Yeah, but why there is hyperemia? Because T1 sympathetic vasoconstriction is gone. T1 sympathetic vasoconstriction is gone. So when the T1 sympathetic vasoconstriction is gone, there will be vasodilation? Yes. And then there will be hyperemia? Yes. There is red conjunctiva, red skin and nasal congestion. These are all features of Horner syndrome. Remember all that. And then this is the pathway you have to understand. There is a hypothalamus having central pathway, and then it is the T1 sympathetic neuron central pathway, and then there will be some fibers ascending up to synapse in the superior cervical ganglion, and then there will be some sympathetic plexus around internal carotid artery, and then you have to control muscles like the dilator pupillae and the superior tarsal muscle. Not only that, but you have to control the blood vessels also on the skin. This is our discussion. Let us do the discussion. Actually, we have to draw the diagram, but before you draw the diagram, you just have an idea. What are you drawing? See, This is called hypothalamus-spinal pathway. Why? Because it is coming from hypothalamus to the spinal cord. How? Actually, it is 3-order neuron pathway. If you say it is the 3-order neuron pathway, where is the first order neuron? It is in the hypothalamus. And where is the second order neuron? It is in the spinal cord. And where is the third order neuron? It is in the superior cervical ganglion. So you're telling that first order neuron is in the hypothalamus, second order neuron is in the spinal cord, and third order neuron is in the superior cervical ganglion. Yes. What is it controlling? Controlling the muscles, like we have told, there is a superior tarsal muscle, part of the Miller muscle, and the dilator pupillae. What will happen if I compromise the pathway? If you compromise the pathway, then superior tarsal muscle will be compromised. The Miller muscle is not working and you cannot elevate the upper eyelid. There will be a partial ptosis in Horner syndrome. And what if dilator pupil is not working? If dilator pupil is not working, sphincter pupil is more powerful. There will be meiosis in the patient in Horner syndrome. Now, you see, this is the 3-order neuron pathway, and injuries can be first order neuron injury, second order neuron injury, or third order neuron injury. Let us discuss 3 patients according to Harrison medicine. What was the first patient? See, this is the first order neuron starting in the hypothalamus. Where is the second order neuron? It is the T1 sympathetic neuron in the spinal cord. If it is the T1 sympathetic neuron in the spinal cord, lateral horn cell, yes, lateral horn cell. So this is called hypothalamus-spinal pathway. And this hypothalamus-spinal pathway is passing in the lateral medulla. And because it is passing in the lateral medulla, when there is a lateral medullary syndrome, Wallenberg syndrome, there is ipsilateral Horner syndrome. If I have a right-sided Wallenberg syndrome, there will be right-sided Horner syndrome. You are telling this is first order neuron injury? Yes. Lateral medullary ischemia? Yes, because this pathway was first order neuron. What will happen? A lot of things will happen. One is loss of sweating on the same side of face. So there will be loss of sweating on the same side of face. Yes. Patient number 1. Now, patient number 2, you have to discuss. See, second order neuron is in the spinal cord. Where is the third order neuron? It is in the sympathetic chain, superior cervical ganglion. So, third order neuron is in the sympathetic chain, the superior cervical ganglion. Yes. How is the pathway moving? It will ascend up the sympathetic chain. Actually, the fibers are climbing up the sympathetic chain. As the fibers are climbing up the sympathetic chain, there is a problem. What is the problem? I got a case of apical lung cancer, which is Pankos tumor. So, Horner syndrome, same side. So, there is some apical lung cancer now. Yes. Leading to ipsilateral Horner syndrome. Yes. Second order neuron injury. Yes. Second order neuron injury, Pankos tumor. Tell me which fibers involved, preganglionic or postganglionic? Preganglionic fibers involved because ganglion is here. So, preganglionic fiber involved. Yes. Second order neuron injury is there. Yes. Okay. Horner syndrome says, will there be loss of sweating on the same side of the face? Yes, of course. Loss of sweating on the same side of the face. Okay. Second patient. Yes. What about the third patient? Third patient is here. You know, the superior cervical ganglion is sending T1 sympathetic fiber making sympathetic plexus around internal carotid artery to supply the superior tarsal muscle and dilator pupillae muscle. Normally. So normally superior cervical ganglion is sending some sympathetic plexus around the internal carotid artery to supply superior tarsal muscle, dilator pupillae muscle there. Yes, but this artery is passing through cavernous sinus and there was some cavernous sinus pathology. So this artery is passing through cavernous sinus. What cavernous sinus pathology you are talking about? Maybe internal carotid artery dissection. So there was some internal carotid artery dissection inside the cavernous sinus. Yes. So internal carotid artery dissection inside the cavernous sinus. Yes. What will happen? T1 sympathetic plexus is compromised, leading to paralysis of some muscles. Features of Horner syndrome. My question to you is, if there is this third patient cavernous sinus pathology, will there be loss of sweating or not? Will there be loss of sweating or not? Understand one simple thing. Wherever the nerve is injured, only distal area will be affected, not the proximal area. Wherever the nerve is injured, only distal area is affected, not the proximal area. Why not proximal area? Because sweat pathway is already given. It's intact. So there is no problem of sweating in this patient. See, wherever the nerve pathway is involved, only distal area gets compromised, not the proximal area. So the sweat pathway was already given. It was intact. There is no loss of sweating in the third patient. We already have dealt with the question. We said when there is a cavernous sinus pathology, there is no anhidrosis. But why there is no anhidrosis? Because sweat pathway is intact. It's already given. No loss of sweating in third patient. Maybe it was Wallenberg syndrome where there was loss of sweating. Maybe it was the Pancoast tumor you had loss of sweating. But in cavernous sinus pathology, there is no loss of sweating on the face. That was the question. Once you have done that, let us draw the diagram. Same diagram we have to draw. So you are drawing the same diagram. Yes. Okay. Let us do it quickly now. This is the brain and this is the spinal cord. And then you will tell this is the hypothalamus on each side. If this is hypothalamus on each side, then which hypothalamus you want to discuss? I want to discuss the hypothalamus on the right side. And then I want to discuss this spinal cord T1, L2. Which one specifically? I want to focus upon this T1 sympathetic neuron. So you want to discuss some neuron in the hypothalamus and T1 sympathetic neuron? Yes, actually, right hypothalamus having a first order neuron and T1 sympathetic neuron, the second order neuron in the spinal cord, lateral horn cell. What is the pathway called? Pathway. Pathway is called hypothalamo spinal pathway, first order neuron. Here. So there's a first order neuron hypothalamo spinal pathway. I think it is passing through the lateral medulla. Yes. There it can be compromised. Yes. First patient. Lateral medullary syndrome, Wallenberg syndrome, and leading to Horner syndrome, the same side. This is our discussion. So what is the normal pathway? First to tell me the normal pathway. Normal. Let us see. We have to supply two muscles. Which two muscles? The superior tarsal muscle, part of the Miller, and also I have to supply the dilator pupillae muscle. So if you want to supply dilator pupillae, I think dilator pupillae has radial arrangement of fiber on the iris. Yes, that is a question already. Dilator pupillae has radial fibers on the iris. So it is being supplied now. Yes, by the T1 sympathetic fibers. It is a T1 sympathetic fibers which will supply two muscles. One is superior tarsal muscle, part of the Miller, and the other is dilator pupillae radial muscle on the iris. How do you supply them? Let us see how we supply. But first you have to draw the sympathetic chain with the sympathetic ganglia. So this is sympathetic chain with sympathetic ganglia. Which ganglia you want to discuss? Superior cervical ganglion. I want to discuss superior cervical ganglion in the sympathetic chain. So you want to discuss superior cervical ganglion in the sympathetic chain. This is the third order neuron. Yes, that will be the third order neuron. First order neuron, hypothalamus. Second order neuron, T1 sympathetic neuron, spinal cord. And third order neuron, the superior cervical ganglion. And let us look at the pathway. See, the first order neuron was in the hypothalamus, synapsing with the second order neuron, which is T1 sympathetic neuron in the spinal cord. What is the second order neuron pathway doing? Climb up the sympathetic chain and synapse in the third order neuron. So second order neuron fibers are climbing up the sympathetic chain to synapse in the third order neuron, superior cervical ganglion. What is the superior cervical ganglion doing? It is sending the fibers to control the muscles. How it will send the fibers to control the muscles? Actually, there is one internal carotid artery. Yes. Around the internal carotid artery, there is a T1 sympathetic plexus. This is the T1 sympathetic plexus. So that is the T1 sympathetic plexus which is around the internal carotid artery passing through the cavernous sinus. Yes, passing through the cavernous sinus. Then it will go and supply the muscles which are here, smooth muscles of eyeball. So you're telling that the superior cervical ganglion has a third order neuron. Yes. And the postganglionic fibers are making some sympathetic plexus around the internal carotid artery which is passing through the cavernous sinus and carrying the T1 sympathetic plexus to the muscles like the superior tarsal muscle and dilator pupillae. Yes, that is the point. And what was the first patient? First patient we said this is First patient. So what happened? It is actually first order neuron injury, hypothalamospinal pathway injury, and there was some Horner syndrome on the same side. On the same side, there was this ptosis, and there was this meiosis also. So there's meiosis ptosis. Yes. Okay. What is the second patient? My second patient is apical lung cancer, and when there is apical lung cancer, there is Pancoast tumor. Yeah, Pancoast tumor. Second order neuron injury. So patient number 2 is apical lung cancer and Pancoast tumor. Yes. Where is that tumor? What is it doing? It is compressing the sympathetic chain here. Apical lung cancer. So there is some apical lung cancer now which is compressing the sympathetic chain. Second order neuron injury? Yes. Preganglionic fiber injury. So this is preganglionic fiber. Yes, this is preganglionic fiber. This is second order neuron, and this is compromised in a tumor which was here, Pancoast tumor. So this is some apical lung cancer, Pancoast tumor, compressing sympathetic chain and compressing preganglionic fiber, second order neuron, and there will be features of Horner syndrome. What about the third patient? Third patient, I have cavernous sinus pathology. This is the third patient. So third patient is some cavernous sinus pathology. You told that there will be some internal carotid dissection. Yes, that is the point. So third patient is cavernous sinus pathology, and there is some internal carotid artery dissection inside the cavernous sinus and leading to paralysis of some muscle and ptosis meiosis, and there is no loss of sweating. No loss of sweating. Why there is no loss of sweating in the third patient? Because this is not the sweat pathway. Then where is the sweat pathway? Sweat pathway was already given, and it was carried by external carotid artery plexus. So sweat gland pathway is carried by some external. Why external? Because skin is outside, external carotid artery plexus. Oh, you are telling superior cervical ganglion would have sent the sweat pathway already, making a sympathetic plexus around these external carotid artery branches? Yes. To reach the skin, sweat gland here. Now, I have told only external carotid artery, but not necessarily. There can be many pathways. One of the pathway is along the external carotid artery, and it's already given. So, if it is already given, then this is a distal injury. Yes, because the distal injury, it will not be presenting with sweat loss and hydrosis because sweat gland is already intact. Wherever the nerve is injured, only distal area is involved, not the proximal area. Proximal area is still working. No anhydrosis in third patient.